warm in the
background at all.
Yeah.
Wave one.
All right, we're rolling.
Okay.
All right. So, when you answered mitral valve regurgitation is, so what is mitral valve regurgitation?
Mitral valve regurgitation is a leaky in valve in the heart. So your heart's a pump. It just beats like this. And blood needs to go in one direction. So it has an in valve and an out valve. The in valve opens, or the mitral valve opens, the in valve closes, and then the out valve will open. If your in valve, your mitral valve, doesn't close right, blood goes backwards to your lungs and causes shortness of breath.
And what are some of the problems that can happen with shortness of breath, and what can that lead to?
So we know over time, even if you don't have symptoms, over time, mitral regurgitation increases mortality. Now, with time, you'll be more short of breath because the pressure will back up into your lungs and cause fluid and shortness of breath. And that's okay. We can fix it, but if we wait too long, even if we fix the valve or replace the valve, we can't reverse that process. So even if you don't feel like you have symptoms and you have a leaky mitral valve, if it's a significant leak, you may be a candidate for a mitral valve repair.
And so mitral valve repair, historically a surgical option. I could first why don't we talk about what the surgical option is and then talk about the new option.
So usually when somebody has a severe or a moderate to severe leaky mitral valve, leaky in valve, we are able to fix it surgically. We can do that through a conventional sternotomy or through a minimally invasive approach. The way we fix it, there's only a few types of leaky mitral valves. Generally, if the leaflets, there's two leaflets, pull apart, we can put a ring and put that valve together. If part of the valve prolapses or if one of the cords are broken, we can actually just cut out that part that's prolapsing and put it back together. Now, that's generally what we do. It's very safe, a very, very low mortality, and we know in people that do a lot of mitral valve surgery, you can fix about 90% of leaky mitral valves.
What is the mitral clip?
The mitral clip is a new evolving technology that helps some patients who are at high risk for traditional surgery avoid that surgery and still will help fix the mitral valve. Now, it's not for everybody, and for patients who are good candidates, it's probably a better option. But in those patients who are really high risk of maybe even not surviving surgery, the valve is kind of like a staple. So you have the two leaflets, the anterior leaflet and the posterior leaflet of the mitral valve, and they tend to want to pull apart. What the mitral clip does is it clips them and brings them back together. And that way, the mitral valve still opens on the sides. It's a double-barrel orifice, but the parts that are leaking, it snares it together. And we can do that with just a groin poke and a little needle instead of an open surgery. So some of the benefits of the mitral clip really is it allows those patients who maybe won't tolerate, surgery is invasive. And even though we've gotten better at it and the outcomes are very good, we've also learned to avoid doing it in people that may not survive it or may do very poorly. So in those groups of patients who are high risk, this is much less invasive and still is able to decrease the amount of leaky valve.
Okay. So I want to move on to hybrid maze.
Sure.
So what is atrial fibrillation?
Atrial fibrillation is a disorder of the upper chamber of the heart. Normally you've got an upper chamber and a lower chamber, and it beats like this. Boom, 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 boom. In AFib, the upper chamber is irregular, and it doesn't squeeze and coordinate. It just kind of goes like this and quivers. In addition, it quivers very quickly, and then sometimes activates the lower chamber to beat very fast and irregular. So it would go boom, 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 boom. This can cause a couple problems. It can cause heart failure right away or long term. It can also, when the upper chamber is like this, blood can pool and clot. That clot can break off and cause a stroke.
So what are the options of treating atrial fibrillation?
Typically, most people with atrial fibrillation get medical therapy. And those options generally mean if the atrium is quivering and you don't want to form clots, you thin the blood. And blood thinners are actually pretty good at decreasing stroke. In addition, if you want to control the rate and not beat so fast, because if you run too fast on a treadmill, you might get dizzy. Well, the ventricle is doing that all the time in atrial fibrillation. We tend to slow down the heart. So one option is medical therapy. Another option for the treatment of atrial fibrillation is a catheter-based procedure called a pulmonary vein isolation. We know in the upper chamber, the quivering chamber, oftentimes an abnormal impulse sets it off, especially when AFib comes and goes. If it's there all the time, it's a little more complicated, but if it comes and goes, usually those abnormal impulses occur on the outside of the heart, called the pulmonary veins. So with a catheter, we can go in and ablate or make a line of scar around the pulmonary veins and block that impulse from setting off atrial fibrillation. Another option for the treatment of atrial fibrillation is actually surgery. Historically, we at times used to go ahead and do a full sternotomy, but that was awfully invasive, and the reason we did that is we need to able to get at the outside of the heart and the inside of the heart for some of the lines of block. So what we do to treat atrial fibrillation is we make a line of block to block the abnormal impulses. And a maze operation directs the impulses through a maze of tiny scars, kind of like a kid's maze, and directs the current, similar to a pond, electrical current through these maze from the upper chamber to the lower chamber. Now, over the last several years, we've developed what we call a hybrid maze. A hybrid maze involves a minimally invasive heart surgery on a beating heart through two small incisions in the chest, where we do part of the maze on the outside, and then when a patient needs more, we actually use a catheter with just a groin poke and make the other lines of scar from the inside of the heart. So what the hybrid maze does is adds a minimally invasive surgery and a minimally invasive procedure together to reproduce the same results of the open, big cardiac surgery. I figure you can break those up.
Okay. So I'm going to keep what you said about AFib already when you talked about blood pooling and going up. Can you talk about what the left atrial appendage is and the blood pooling there?
The atrium in atrial fibrillation is just quivering. And the structure is like any other structure or any pond. If you go to a pond where the current's flowing through, things tend to be clean and washed away. However, on the side where current's not moving through, that's where things tend to stagnate and build up that you don't want. The appendage is a little outpocketing of the upper chamber of the heart. The left atrial appendage is on the left side. And when blood's pooling and not moving through so well, it goes through the center pretty well, but it tends to stick. And the current doesn't move around in the left atrial appendage. So that turns to be the source of clot in about 90% of the people that have atrial fibrillation and stroke.
It's a significant stroke risk. Why is that?
So the reason why is number one.
The reason why it's
Sorry.
a significant stroke risk.
The reason why the left atrial appendage has played such a significant role in stroke is it's a fairly large structure. For example, sometimes stroke occurs from your carotid arteries. This appendage is about as big as my hand is right here at times. That's a very big amount of clot that can form. And if that much clot forms and breaks off, it tends to be a much bigger stroke than when a smaller one embolizes from somewhere else. So strokes from atrial fibrillation tend to be much larger, more devastating, and more often fatal.
And what is the lariat procedure?
So there has been, based on what we've learned, about the left atrial appendage in open surgeries, and we take it off in all the open surgeries that we do AFib surgeries on, we've learned that removing or eliminating that left atrial appendage is actually a good thing in reducing stroke. So there's newer procedures that have come out that are less invasive that just address the atrial appendage. One of these procedures is a lariat procedure. The lariat procedure is a minimally invasive procedure using just a poke here and a poke from your vein and snaring down the atrial appendage from the outside and eliminating it from the circulation of the heart. This decreases the amount of pool area the clot can form, and we think over time will decrease stroke.
Let's see. So these other, do you want to talk
The
about
Watchman.
Watchman?
The Watchman is a very exciting device that walls off the atrial appendage from the inside. It's one of the only devices that have been studied in a randomized prospective fashion compared to blood thinners. And what they've learned that when you have the atrial appendage and you wall it off from the inside so that blood can't pool there, it's as effective as using blood thinners in reducing stroke. So for those patients who have atrial fibrillation and can't take blood thinners long term, this may be one of many devices coming down the road that will help those patients reduce stroke.
Lead extraction.
Mhm.
So why would a patient?
We have about 200,000 people in the United States that have leads within their heart. Those leads are very good because oftentimes they need them for pacing the heart because the heart's electrical disorder is disordered and doesn't work on its own, so you need to just pace it for itself. Or sometimes the people are predisposed to having arrhythmias, and you can put a device in to actually shock the heart. Now, like everything we make, nothing is made long term, and if you have one lead and you're young, chances are you'll need more down the road. Now, your vein does not get bigger, so the more leads you put in, the more chance of completely closing off that vein, or actually the lead itself getting infected and causing an infection in the heart. So what lead extraction is using a laser and an endovascular, minimally invasive technique. We can use the laser to disrupt the scar that forms between the body's blood vessels and the leads. So we use fluoroscopy in a hybrid operating room, and we remove the lead so they won't build up and close off the entire vein, and so that it won't get infected down the road.
And talk about the difference that it is with laser lead extraction, the approach here versus most places.
One of the things I'm most proud of that we do here at St. Louis University Hospital, when we approach patients, it's really not, it's a lead management it's an approach. It's not surgical or cardiology driven, but it's really a team of specialists that addresses lead problems. In some patients, the lead can be moved quite safely without the need for intervention. However, in any patient where we'd have to use the laser, a surgeon and EP are present there for the entire procedure. Why is that? Well, if there is a problem, and problems occasionally occur, a surgeon, such as myself, can open up the patient and fix the problem right away. If there's a problem with the electrical portion, instead of having someone who does it infrequently, our EP physicians can immediately address the electrical problem, and a patient really gets the best of both worlds for the lead management program at St. Louis University Hospital.
Do you want to talk about Reveal Link?
Yeah, because I have a study coming out. We submitted for the STS.
You told me about that.
Yeah, well, we'll see. It's submitted. We'll see it. I think it should get on. The Reveal is a really new, exciting new technology. This was just published in the New England Journal of Medicine on some levels. It's a very small device. It's about smaller than my pinky, actually. And you can insert it underneath the skin and watch or monitor your arrhythmia or your heart rhythm continuously for up to a few years. Now, why is this important? Well, oftentimes people have a funny heartbeat or don't feel right, but we can't detect the rhythm because we don't have EKGs on them. By having just this small little device under the skin, we'll know if they have an irregular heartbeat or atrial fibrillation and know it continuously over about a 3-year period. When these disorders occur, we can treat them. if we didn't have the reveal in, we wouldn't even know that it existed. One of the most impressive things about the reveal is a study that was published in the New England Journal of Medicine. And they looked at patients with stroke. It was called Crystal AF. If a patient had a stroke, they went through the routine workup, but oftentimes nothing was found. So about 25% of the time, a stroke is cryptogenic, or we can't find out what caused it. In those patients, they put in a reveal monitor underneath the skin. Now, believe it or not, over time, it was found that about 30% of those people, 1 in 3 or so, actually had an irregular heartbeat, predominantly atrial fibrillation. So by using the reveal, we were able to detect many patients and treat them with blood thinners to prevent future strokes.
One other thing, the radial cath, if you want for Dr. Lynn.
That's for him, yeah.
And then the leadless ICD. Do you want to talk about that?
Yeah, I'll let him do that. I was part of the solo trial initially here with Lisa Schiller, but I'm not up to date on the terminologies.
You know, one thing I did not get from you is the role you played with developing hybrid maze. I probably have to do that.
So, as new technology evolved, many of us thought about doing the hybrid maze or some combination. I was one of the early people that embraced the idea and moved it forward. And in fact, I don't know that anyone was earlier than me in terms of a staged approach. So early on, we were doing minimally invasive AFib surgery and found that although it helped a lot of people, it helped about 2/3 of them. And there are about 30% that were not successfully treated with just the minimally invasive approach. For that population, we reached across to our EP colleagues and started up the hybrid maze. We've been doing it now for, I guess, nearly a decade, and overall our results we're very proud of. We feel it offers the patient about as good of a chance of a cure as an open surgery, and we've published this data. But the complications seem to be significantly lower, and the return to work certainly is a lot less.
I think I'm good. Is there anything else that...
Maybe we have a couple more things about mitral valve repair.
Sure.
We're really proud of what we've done here at St. Lucie University Hospital because we've really built a very strong atrial fibrillation and mitral valve repair program. Oftentimes, the two go hand in hand. Unfortunately, many of the surgeons who treat mitral valve disease don't always have a lot of experience in atrial fibrillation, and vice versa. We also believe atrial fibrillation decreases life expectancy. So what we've done in our program is treat both mitral valve disease and atrial fibrillation. And we believe we're making a big impact and improving patients' quality of life, duration of life, and decreasing future stroke. That's okay?
I'm good if you're good.
Yeah, I think that's good.
You're great.
I mean, we could talk.
Oh, here,
All right.
Mr. Merrill, because I don't know.
Oh,
I already talked to Fred.
yeah, thank you.
Made some shit up. Hope it sounds okay.
Yeah, well, it'll take like 2 minutes.
What we doing? What we talking about?
All right, so this is following up on going down the list of like 8 to 10 heart procedures. These are videos will supplement
Got it.
that section. And I sent a list last night. If you didn't look at it, I understand.
Nope.
But what I'll do is kind of alternate cuts back and forth with you and Dr. Lee, although I did not ask Dr. Lee about radial catheterization. I'll do all of that with you.
Okay.
And then leadless ICD, I'll just do with you. I didn't ask him about that.
Okay.
So, so I'll just ask kind of the same lines. What is this medical problem, mitral valve regurgitation, for example, and what are the treatment options? And then it'll get into, we'll get to the mitral clip. And then he actually talked. He wanted to do some. I asked if you guys had anything you wanted to throw in. He talked about an AFib repair program. That was how he defined it.
Yeah. Okay, I get it. So
I'll ask and then,
you're asking me the same questions that Rick
yeah,
asked,
and then I'll just edit back and forth.
and then you're gonna.
together. And then,
Well,
there's
you
one
really.
version of it that somebody else did that I'm kind of stealing the concept from. where-
Okay.
But I'm gonna have two people in it, and then it'll have graphics that'll come in to kind of support. So if you're talking about atrial fibrillation, I'll just put something up that affects 20 million Americans. I think 20 million. I have to look it up. You get-
That's a good idea.
All right. So what is mitral valve regurgitation?
So mitral valve is one of the 4 valves in the heart. It's the valve that sends blood from the top chamber of the heart, the left atrium, into the bottom chamber of the heart, which is the main pumping chamber, the left ventricle. And if that leaks, it means that when the main pumping chamber actually pumps blood, instead of sending all of its blood outward to the rest of the body, some of the blood goes backwards where it already came from. And so the rest of the body can't gain benefit from getting blood. And so it turns the main pumping chamber of the heart into something less efficient. And it can only go on for so long working as a less efficient pump.
Can this cause breathing problems?
Absolutely runs into a concept of you can be short of breath. You can potentially not do as much activity-wise before you have to stop, most of the time because of shortness of breath. And ultimately, if we don't deal with this in a soon enough time frame, it can lead to permanent damage of the main pumping chamber of the heart, which is very hard to recover from.
And what are the treatment options?
Treatment options run the whole gamut. So there's treatment options from a standpoint of medical therapy, where we try to give medicines to encourage forward flow and encourage efficient pumping of the main pumping chamber of the heart. And some people, especially with milder forms of mitral regurgitation, that is the treatment. The other end of the spectrum, we have a surgical treatment where we either have a surgeon repair the mitral valve, which means you take the actual structure that's there and you trim some and you use other rings and modalities within the operating room so that you have your own valve that ends up working that doesn't leak without anything artificial, or a replacement, a surgical valve replacement. And so that's at the other end of the spectrum. The cool thing is that we're developing this area in the middle where by catheter we can go into the heart, and we have some means now with certain patients that we can provide a clip or a staple where we staple the 2 leaflets of the valve together, and we can decrease mitral regurgitation significantly without an open heart procedure. We can help patients breathe significantly better, feel significantly better, and allow them to have a better overall quality of life without surgery when medicine fails.
Do radial catheterization. So when you answer it, I guess say radial catheterization is, and then talk about what the procedure is.
Well, radial heart catheterization is a procedure which is the same as a regular heart catheterization. And that procedure we do most of the time to look for blockages in the blood vessels to the heart. And so we're looking for those blockages. And the symptoms that those usually cause are chest pressure or chest pain or chest discomfort. And to look for those, we have to do a heart catheterization procedure. Radial means where we go in. And the radial artery is in the wrist. And so instead of the traditional standpoint where we put the tube in from the leg and go up from the groin through the blood vessels up to the heart, we put the tube in the wrist and follow the blood vessels in the arm to the heart. We get the same quality of information. We can do pretty much everything we want from the wrist with respect to the types of heart catheterization and the types of things we can do with it, but it turns out to be twofold beneficial. One is it's been proven to be safer for patients with respect to the complications they have, and 2, it's far more comfortable following the catheterization procedure, because when we get done we put a band on the wrist, and you can sit up, you can eat, you can drink, but you're sitting up, versus if you have it done from the leg, you have to lie flat for a period of time afterwards. You can't lift your head, you have to lay flat on a bed, and it's reasonably uncomfortable. You also have to have that tube removed, and when we remove that tube, we have to apply pressure. That's reasonably uncomfortable as well. So safer, more comfortable. We can still do everything we want from the wrist that we could do from the leg.
Getting into atrial fibrillation, then, what is atrial fibrillation?
Atrial fibrillation is an abnormal heart rhythm. It turns out to be the most common abnormal heart rhythm in the world, and especially in the United States. The normal heart rhythm is a sinus rhythm, and that means that the top chambers beat and then the bottom chambers beat, and they're synchronized like a nice clock or a nice wristwatch. Fibrillation means that instead of beating or contracting, they kind of shake, and that's what fibrillating means. It means it kind of shakes or wiggles back and forth. And so atrial fibrillation means that the top chambers of the heart, instead of contracting and beating, are just quivering. And as they quiver, they don't really move blood flow very efficiently. They allow blood to pass through to the ventricle, but they don't push it through. And that is one of the primary problems. The second problem with atrial fibrillation is that as the atria quiver and the blood isn't pushed through, it can pool within the atria and sit there for quite a period of time. And that period of time is potentially enough for blood clots to form. And if blood clots form in the atria, then those blood clots can go someplace. And so the biggest problem we have with atrial fibrillation is those blood clots going to the brain and causing stroke. And stroke, as we know, is a devastating problem that most of us would like to avoid.
So you have a procedure using a device called Lariat. Talk about that.
So to prevent stroke, we have multiple different options for people with atrial fibrillation. First of all, we risk stratify people who have atrial fibrillation because not everybody with atrial fibrillation is very high risk for stroke. Some people are lucky and they're at lower risk for stroke. They can potentially take things like aspirin. When you're at higher risk for stroke, there's medical therapy where we put you on blood thinners, of which there's an assortment now. There's warfarin or Coumadin and newer agents which thin your blood so that the clots don't form. Some people are intolerant to those, some people can't take those, and that leaves us two other options. One is an open heart operation where we go in and actually remove the left atrial appendage surgically. And the left atrial appendage is an outpouching of the left atrium where the clots, 90% of the clots form in atrial fibrillation. So if we remove that, then we remove a big pool of where those clots come from that potentially cause a stroke. The non-surgical option is a catheter-based option where we put a tube up through your leg and we also put a tube up from the middle of your chest and we encircle that left atrial appendage with a lasso and we cinch that lasso down and that leaves a stitch which permanently closes that left atrial appendage for some people who are candidates. So you have to have the right anatomy and the right history for us to be able to do that. But we can get rid of the left atrial appendage. Thereby, if you can't take Coumadin because you've had a bleeding issue, then we can get rid of the left atrial appendage by the Lariat and hopefully reduce your risk for stroke.
Should we talk about WATCHMAN?
No, because it's been delayed even further.
Okay.
So it's not going to be 2014. It's going to be 2015 at the earliest. The FDA's asked for another panel.
Well,
Damn government. Put that on the website.
What I could do is just I have it on tape and I can use it for.
I mean, but Mark, don't put it on the website.
No.
And it says
But
that.
I can hold on to
Yeah,
it.
this just happened last week, but the FDA is going to ask for another panel, and so it's giving people false hope. Lariat and the surgery and the blood thinners is our treatments right now.
I'll let it go. Do you? I mean, he talked a lot. I asked him about hybrid maze. Do you want to talk about that, or you just want to leave that all?
Well, if he wanted to push this program, so we've talked about the mitral thing, we talked about AFib. If he wanted to put this push this program of AFib repair, we might also want to, if it's okay with you, talk about how things are kind of combined.
Yeah.
And so how we deal with mitral regurgitation in the valve clinic, but also we pick up AFib and we deal with the whole patient
He
concept.
talked all about that.
So you want to just use his is fine with me.
Well, if you have anything to weigh in on it more than mine, you do. This is so much better. It's not even funny. If you could, we won't show him that. If you could talk about it.
There's a lot of things going back and forth in my mind about that. But I want to be complimentary, and you need to be able to be fair and balanced. So
I know. Well, I know. I will. He actually he has a very different style than you. He says, so what is mitral valve regurgitation? Well, and then so it requires more editing, and he actually does a very good job. It just he has a different style.
so whatever you want me to say that would help you, just tell me.
Well, he did a very
Tell me
good
what you
job
want me to
talking
cover.
about exactly what you said. If you have anything more to elaborate on it.
Okay. No.
Okay.
And the only thing I would elaborate, I guess, would be I can give you one thing. It's about, I will, but I'm just talking conceptually. It'll be about sort of why you should come to see us in a comprehensive evaluation clinic, where you see the heart doctor and the heart surgeon concept.
Okay. That's the valve clinic.
Well, it's all of our clinics. So like AFib clinic and a valve clinic are just two of them, but yeah. So the Comprehensive Center for Cardiovascular Care, the first word is comprehensive, and what that means is we focus on being able to offer treatments all across the board by multiple specialists. And so we have an atrial fibrillation clinic where we have general cardiologists that can help you from a medicine standpoint. We have heart rhythm specialists, which can help you from a catheter treatment standpoint. And we have heart surgeons that can help you from the surgical aspects of that problem. And so you get the ability to have all of those opinions in one setting. The same thing with our valve clinic, where we have myself as a catheter-based valve person meet with you at the same time as our heart surgeon, Dr. Lee, meets with you from a standpoint of the surgical valve treatment options. And so to contrast what you would get from a comprehensive evaluation versus what is typically offered, typically your doctor will detect a valve problem and refer you to a valve surgeon. And that valve surgeon, being very good at doing valve surgeries, will talk to you about valve surgery, but may not talk to you about what your non-surgical options are. Same thing with atrial fibrillation. They might refer you to a catheter-based electrophysiologist or heart rhythm specialist to deal with your atrial fibrillation, but they might not think about the fact that a mini maze type procedure might be the actual better treatment or another treatment option for you to consider. So you don't get all your you don't get all your options necessarily. In a comprehensive clinic, what we try to do is in one setting allow you and your family to have multiple options if we can provide them. They don't necessarily focus on what our absolute specialty is, but they actually focus on you as the patient and what is the right thing for you, and allow you and your family to make the decisions which you feel most comfortable with in taking care of your heart. You can add that.
A couple I have left. Do you want to talk about lead extraction?
Sure.
What is lead extraction?
So when we talk about lead extraction, what we're talking about is actually pacemaker defibrillator wires, which come from the box, which is typically underneath the skin right below the collarbone. And those connect that box down to the heart. And those wires can get old. Those wires can break, which we call fracture. Those wires sometimes can get infected. And the standard practice is many times those are just left. And so they'll be what we call capped. So that wire will just be left in place and a new wire will be put in. Well, there's only a certain amount of room that the veins that these wires go down to the heart actually can accommodate. And so when you start sticking more and more wires, you potentially plug the hole. If they're infected, obviously we want to remove them. And so now we need to talk about removal of these leads, or what is the safest way to remove these leads. In our comprehensive program of lead removal, we actually employ a heart surgeon and the lead expert or the rhythm doctor at the same time for your benefit, where the heart surgeon will use a device called a laser to safely get rid of all the scar tissue and all what we call adhesions where that lead is stuck in place, and be able to retrieve that lead safely. And then the heart rhythm specialist, who is the expert at re-putting in those leads, pacemakers and defibrillators, re-puts a new lead down into the heart. And in that team approach allows you to have this procedure done safely and efficiently in one setting. Obviously, when the lead is removed, one of the worst things we fear is that there's a hole left behind in the heart, and blood can accumulate around that heart. If that would happen, we have the heart surgeon right there. We can recognize that immediately, and we can treat that complication with very little chance of long-lasting problems for you. And that's the beauty of why you want a comprehensive program that takes care of your leads.
Let's go to the reveal link. So, what is the reveal link?
The reveal link is what we call an implantable loop recorder. What does that mean? That means that it is a small device that is implanted under the skin, just to the left side of the breastbone, that monitors heart rhythm continuously for up to 3 years is how long the battery life lasts. That's in contrast to sometimes people are asked to wear monitors that are external. They have to put patches on. They have to carry around a box. Sometimes people don't have the symptoms of that heart rhythm when they're wearing that box. Sometimes the patches don't stick. Sometimes the quality of recording that occurs is not good enough for us to know what kind of rhythm is bothering you. And so the reveal link, or the loop recorder implanted under the skin, alleviates all those problems. We don't have to worry about patches sticking. The quality of recording is excellent. And we don't have to worry about not having the arrhythmia happen, because we have a 3-year window of which to look at somebody with respect to when that happens. The other cool thing about the link is that it talks wirelessly to a box, and that box can transmit by a cell phone signal what's going on with your heart rhythm at that time and over the last however long you want, to us directly to our computer, and we can see what's going on. When you say you have symptoms, you can press a button, it sends us that signal. We know what's going on with your heart, we know what the rhythm is, we can reassure you, we can tell you what the problem is, and we can offer you treatments based upon it. And so it really advances our ability to detect rare or infrequent palpitations or other things that can be rhythm related, and be able to diagnose them with more certainty.
How are we using this with the Mid-America stroke?
So a significant number of people who have had a stroke, we can't find the actual cause of the stroke. And obviously somebody who's had a stroke, they're at much higher risk of having another one. And if we're lucky enough to have had a stroke and have minimal symptoms, the last thing we want is to actually have this again. So if we're at higher risk, we really want to know what the cause is. It turns out that a significant group of people who have already had a stroke actually have what we think is paroxysmal, or only every once in a while, atrial fibrillation. What that means is you didn't have the atrial fibrillation when you were hospitalized for your stroke. You don't necessarily feel that you're going to atrial fibrillation versus being in the regular rhythm, but it's enough so that you can have blood clots in your heart that can go up to your brain and cause another stroke. And so when we have people who we can't figure out what the cause of the stroke is, we put the reveal link or the loop recorder in to be able to monitor you for any occurrence of atrial fibrillation. And if you have some of that, then we can offer our treatments for that atrial fibrillation centered around preventing another stroke.
Leadless ICD. Why would somebody need an ICD?
I got it.
Dive right into the leadless part.
So an ICD is an implantable cardiac defibrillator. And why would somebody need that? some people with weakened heart muscle pumps are at higher risk for having bad heart rhythms. And those bad heart rhythms aren't capable of sustaining life. And that's when they need an electrical shock to get them out of that heart rhythm into a heart rhythm that can sustain life. So it's really it's all about odds. So we look at certain profiles of heart patients, and we find those patients that are at higher probability of having those heart rhythms, and we say those patients can potentially live longer if they have the defibrillator in place, or the ICD. The traditional ICD is placed underneath the collarbone, under the skin with a small incision, with leads that go down to the heart. Those leads detect what heart rhythm your heart is in all the time, can determine whether your heart rhythm is a bad one, and then deliver a shock if your heart rhythm is a bad one to try to get your heart back into a good heart rhythm. There are some problems with having leads inside of the veins and inside of the heart. They can have blood clots attached to them. They can get infected. And so some people would rather not have any leads or wires from the defibrillator to the heart itself. And we can offer what's called a leadless ICD, where the defibrillator box is actually placed, instead of up here, down here in the midline below your armpit, and there is a lead that goes underneath the skin to about here and then up beside your breastbone to about here. It can provide almost all of the same functions, where it detects what your heart rhythm is, it can detect whether your heart rhythm is abnormal, and it can deliver a shock to get your heart rhythm into a normal rhythm and potentially save your life. So I call ICDs actually the best life insurance policy that benefits you as the patient, because you get all the benefit and it allows you to potentially live longer.
I think we're good. Anything else you want to talk?
I don't know, you got the cameras here, so this is your nickel, man.
Should we talk about pulmonary vein isolation? I don't know. He talked about it, but I don't know in conjunction with hybrid bays.
Yeah, we can talk about, when you talk about the different treatment options for AFib, so hybrid maze is sort of, it includes a minimally invasive surgery option, but there is a separate pulmonary vein isolation, which is just a catheter-based procedure, so it's...
So what is pulmonary vein isolation?
Pulmonary vein isolation is a procedure where, by a catheter or a few catheters which go up through your groin, we can go into the left atrium of your heart and make electrical burns, which utilize actually radio frequency energy, which make scars. And those scars inhibit the ability of electrical signals to go through the scar. And so the theory with respect to how this works for atrial fibrillation is that there's a bunch of tissue that's around the tubes which enter the left atrium. And that tissue is kind of like the kid in the classroom that's sort of the guy who always is a troublemaker. And so when the teacher figures out which kid in the classroom is the troublemaker, the teacher always puts the troublemaker up closest to their desk. And the troublemaker is somebody who has a close eye on them, they can't cause a trouble anymore. Pulmonary vein isolation is similar because the tissue around the pulmonary vein is the troublemaker. And if we make a scar around where those pulmonary veins enter the left atrium of the heart, then those troublemakers actually can't talk to the heart itself. And so those signals never get down there, and the heart never has a chance to go into atrial fibrillation. And so, especially for people with paroxysmal atrial fibrillation, who are very symptomatic from it, they feel when their heart goes into AFib, they feel that palpitation feeling, and they don't like it at all. And it inhibits their ability to exercise, it inhibits their ability to carry on normal activities. Pulmonary vein isolation in and of itself as a catheter-based procedure can be a complete cure. As opposed to people who are asymptomatic, we wouldn't necessarily offer this to, as opposed to people with more chronic atrial fibrillation, which is what we call persistent. And those patients might be better off for having a minimally invasive maze or mini maze, or potentially a hybrid maze type procedure where we can do more to control the electrical activity of the heart than just what catheters offer.